for me to cover, but in any case, I will definitely try to cover it so that you people would be able to understand. उसके बाद जो भी चीजें there will be missing things like what you are saying, we will try to cover up that in some other area, right? Okay. Can you see my screen?
Yes,
For me?
sir.
Yes,
Perfect.
sir.
Yes, sir. We can.
Should I continue?
Yes, sir.
Okay, let's see.
Yes.
Okay, बिस्मिल्लाहिर्रहमानिर्रहीम। वो एक शेर है पुराना, जिंदगी से डरते हो, जिंदगी तो तुम भी हो, जिंदगी तो हम भी हैं, आदमी से डरते हो, आदमी तो तुम भी हो, आदमी तो हम भी हैं। कभी कभी पाकिस्तान के हालात देख के ना तो दिमाग थोड़ा सा अजीब सा हो जाता है। सो ऐसे ही बैठे बैठे मैं देख रहा था तो ये शेर मेरी नज़र से गुजरा, सो मैंने सोचा वी आर ऑल अफ्रेड ऑफ ईच अदर रादर देन we want to do something for each other. Anyways, good to know that things are relatively better. Movement disorder. The term movement disorder refers to a group of nervous system which is neurological conditions that can cause either increased movements or reduced or slow movements. These movements may be voluntary or involuntary. So all the parameters, voluntary, involuntary, uh, again, excessive movements or reduced movements, they are there. And as I mentioned a couple of times earlier, that this topic is basically to be covered by the neurologist. It's not a psychiatry topic, but I'm just trying to cover it to facilitate you people. Okay. Basic movement disorders. This is the brief outline of all the things that we can see in psychiatry. So there can be pyramidal syndromes, basal ganglia disorders, and cerebellar disorders. So three major areas where the movement disorders have the origin. One, pyramidal; two, basal ganglia; three, cerebellar. And we know that these three structures, we have to assess them when we are examining a psychiatry patient. So always remember, the movement disorders are only because of the three main regions of the brain: basal ganglia, pyramidal, and cerebellum. And when you are examining the patient for neurological assessment, you have to assess all of these three. You will assess the pyramidal system, the basal ganglia, and cerebellum. Now, if it is pyramidal system, then it can lead to spasticity. So spasticity and related syndromes with spasticity can be there, like dystonia, like other disorders. If it is related to the basal ganglia, then there are two major things: hyperkinetic and hypokinetic. And if it is cerebellar, then there is ataxia. So if there is ataxia, it is most likely related to cerebellum. If it is spasticity, it is more related to pyramidal system. And if it is hyperkinetic or hypokinetic, it is basal ganglia. Are you clear about it? So three major regions of the brain. Pyramidal leads to spasticity. Basal ganglia leads to hyper or hypokinetic movements. And cerebellar disorders leads to ataxia. Now, if it is hyperkinetic or hypokinetic related to the basal ganglia, then there are various possibilities. One, hypokinetic means slow movements. So it could be stiffness or it could be slow movements. And hyperkinetic leads to maybe the diagnosis is chorea, dystonia, myoclonus, tics, stereotypy, or tremor. So if you're seeing a tremor, then this means that this is a hyperkinetic disorder, which is secondary to the basal ganglia, leading to a movement disorder. If it is tics, this means that this is hyperkinetic disorder from basal ganglia leading to movement disorder. But if it is stiffness, then it is hypokinetic leading to basal ganglia, originating from basal ganglia, and it is a movement disorder. So remember, basal ganglia leads to two different kinds of movement disorders, hyper or hypo. Hypo is stiffness and slowness, and hyper is chorea, dystonia, myoclonus tics, stereotypy, or tremor. Clear? Okay. Now, how do we screen and further proceed with it? The first and the foremost thing is that we have to make sure that whenever the patient is coming into the setting, is he taking antipsychotic medications, or are they ever treated for abnormal movements problems in the past? If they are treated, then the approach will be different. So we have to shut down all the medications. We have to assess them from the baseline. We have to apply various tools, investigate, blah, blah, blah. If it is not like this situation, and the patient is not taking antipsychotic and he is having abnormal movement disorders, but he has never been assessed for it, then conduct baseline assessment and continue regular monitoring for abnormal movements. Screening assessments can be informal, like observation, or they can be formal. The formal means you can apply AIMS, BARS, ESRS, SAS, or it could be both. You assess them informally and you apply the test as well, which is a relatively safe option. So if you see a patient coming with the movement disorder, now the first thing is you have to assess whether this is from basal ganglia, this is from the pyramidal system, or this is from the cerebellum. Second, you have to assess the patient informally, like examining the patient, neurological examination, other investigations, file work, blah, blah, history taking. And if that is covered, then you will apply these tests, AIMS, BARS, ESRS, SAS, or all of them. Then, once you are doing this, during this process, you have to again understand that the patient should be able to assess himself as well, and you have to educate him that these kind of the movements, you have to make a record of it, when they are happening, how they are happening, they are continuous or intermittent, or they are regular or irregular, or they are occurring unilateral or bilateral. All of these kind of things you have to tell them. You have to also tell them that this could be a side effect of medication, or this could be something new developing and we have to proceed further, and this may take some time. And also try to give them some material, of course, not on from the websites, but maybe simple Urdu version of some educative material related to the movement disorders. I don't know any of them available in Pakistan, but still that is the best option to move forward. We have to make sure that the patient understands that he has to take the medication for movement disorders. The medication cannot be stopped suddenly. It's a lifelong process. And till the time we reach to a specific morbidity, we should not make any plans of alteration in the lifestyle. So that is important as well. Now, this is AIMS. I'm sure all of you have this scale, and this is very simple and it is universally accepted scale, so it can be applied. Surprisingly, AIMS is available in Urdu as well. You can get it from various sources. If you don't be able to reach out for that, let me know. I'll find out for you and I will give it to you. So the movement disorders could be facial and oral movements, extremity movements, trunk movements, and overall severity and patient's awareness of abnormal movements. You rate them, and if the patient is falling between moderate to severe, he needs definite intervention. If it is mild, only the observation can be continued. There is Unified Parkinson's Disease Rating Scale, UPDRS. Well, this is again related to the same situation where you have to assess various parameters, intellectual abnormality, thought disorders, aggression, some motivation, activity of daily living, speech, again, salivation and swallowing. All of these movements needs to be assessed. Two tests of selective motor control. One is SMC, selective motor control, SMC, and there is another scale. Whenever you want to apply any of the scale or any of the tool, make sure that that tool is validated and it would be able to cover what you want to cover. Basal ganglia, cerebellum, or the pyramidal system. If there is a scale which is not covering pyramidal system, but it covers only the basal ganglia, like you want to assess for tics or myoclonus, then of course it will be different. It will be very specific test. Try in psychiatry not to use these general specific tests only for tics, only for Parkinsonism, only for again coriform movements. It's much better and approachable if you take an opinion of a neurologist if you feel that the person is having basal ganglia problem and he's having myoclonus. So the neurological opinion is much more appreciated than you going for specific test, right? This is appreciated as a psychiatrist. Now, as I mentioned in my past slide, so if there is a problem with cerebellum, ataxia is the main presentation. Now, what is ataxia? Ataxia is degenerative disorder affecting the brain and the brainstem, specifically the cerebellum and the spinal cord. This can result in clumsiness, inaccuracy, instability, imbalance, tremor, and lack of coordination. So the patient may be sitting comfortably in front of you, and when you ask them, okay, hold something, they may go like this, and they won't be able to touch that specific thing, go here and there and pick up. So it will take some time. And second, again, lack of coordination may also lead to tremors. So there is shakiness in between that. And if you want to make them walk, they are not able to walk as in a straight line. So ataxia is abnormal taxia, means movement, which is mostly related to posture and the gait. That is the key. So at rest, they may be okay, but as soon as they are moving and doing something, ataxia can be seen. It can affect the speech as well and movement of the eyes as well. But usually, again, this is relatively uncommon. Movements are not smooth and may appear disjointed or jerky, and patients may fall frequently due to an unsteady gait. So, main presentation of ataxia, which is related to the cerebellar problem, is that these people are falling multiple times. Old age, young age, if the falls are a frequent presentation, consider cerebellar abnormality, consider ataxia. Then what should we do? If we see that, okay, this patient is following multiple times, there are gait disturbances and they are clumsy, unstable on their feet, what should we do? First, we have to rule out the metabolic disorders. Second, we have to rule out Parkinsonism. Third, we have to make sure that they are not taking any medications other than that. And if we have to prescribe any medication, mostly they are anticholinergics, dopamine agonists, amantadine, selegiline, and entacapone. All of these medications are available in the market in Pakistan, except for amantadine, which is relatively short, but they are available. Mostly, if the ataxia is in children, we try to avoid other medications in children, and the anticholinergics are the mainstay. So entacapone, selegiline, dopamine agonists are usually not given to the children. Children are mostly prescribed anticholinergics like procyclidine. So that is relatively considered to be safer in children. So this is what the basic treatment is. Dystonia. Again, now dystonia comes under the heading of abnormality of basal ganglia. So dystonia is a neurological muscle disorder characterized by involuntary muscle spasms. Right? There is a stiffness. And this results from abnormal functioning of the basal ganglia. A deeper part of the brain which controls the coordination of the movements. I don't have to go through that. Patients with dystonia may experience uncontrollable twisting, repetitive movements, or abnormal postures and positions. So they may be sitting like this for a long period of time. And you say, okay, now there is no disturbance as such in the gait and walking, but they are walking in an abnormal, again, position, which is not usual. So you will see that there is stiffness of some parts of the body, and it could be dystonia. Now, dystonia has multiple presentation. It could be focal dystonia, or it could be generalized dystonia. Focal dystonia is usually specifically related to some organs like blepharospasm. I have seen at least 10 to 12 patients who are under my care with focal dystonia. So nothing was happening except for the blepharospasm. He was not able to open up the eyes, right? And there is twitching of the eyes frequently. So it is very, again, if I have seen it and he's coming to me, this means it was common. So blepharospasm, then Mage syndrome, lower half of the face is stiff, or limb dystonia, only one limb, bilateral limbs, only lower limb, upper limb, depending upon what part of the body is affected in the pyramidal system, that is a problem. Treatment of dystonia. Treatment of dystonia is three-tiered approach. One, you first of all, you try the anticholinergics. If he's taking an antipsychotic medication, then you can change the antipsychotic medication, give him anticholinergic. I'm not in favor of giving too many anticholinergics. If the dystonia is a problem, I prefer to change it because, again, I want to stick to the monotherapy because all anticholinergics can lead to worsening of the psychosis, worsening of the tardive dyskinesia, and sometimes worsening of dystonia as well if the origin is basal ganglia. So I am usually careful about it. But of course, this can be done. The second is Botox injection. So if the blepharospasm is a problem, lingual dystonia is a problem, if the Mage syndrome is a problem, then it is recommended to go for, again, Botox injections, which is considered. And if that won't help, then of course surgery is the result. Then comes the essential tremors. Essential tremors is an uncontrollable shaking or trembling, usually one or both hands or arms, that worsens when the basic movements are attempted. Now again, if they are sitting in the resting position and they are trembling like this could be tremors, but mostly at rest, they sometimes disappear. With the voluntary efforts, they may disappear. But of course, the neurologist would be able to explain this better to you. It is caused by the abnormalities in the areas of the brain that control the movement. So again, basal ganglia. About 50% of have the family history and this condition. This condition usually does not result in serious complication, but it definitely impairs the quality of life. So they are able to carry on their day-to-day life things. These patients can be working in the office, they are absolutely fine. If it is not drug induced, it is essential tremors without any specific etiology, they may be fine, but their quality of life is disturbed. So again, the background check, the history, the information is very important to reach to this. Now, again, the treatment stays the same. Most of the time, the physician prescribe beta blockers for the essential tremors. Again, for me, it is not the best choice. Now, anti-seizure medication or the beta blockers, I usually avoid them. Best is either you give benzodiazepines or you give anticholinergic drugs. And the safe option is carbonic anhydrase inhibitors. So this is the third line drug, which I prefer is a better than the previous ones. Carbonic anhydrase inhibitors. If it starts having complications with general things, like they start having the memory issues, they start having the movement issues, they start having the delirium or other complications, then of course you have to go for the detailed assessment and other treatment options. Huntington's disease. Now, I have seen in my life only two patients suffering from Huntington disease. Actually, both of these young adults at the age of 2022 presented to the inpatient psychiatry with psychosis, not movement disorder, but with psychosis, which is one of the complications of the Huntington's disease. And then when we assess the family, there was definitely a strong family history of Huntington's disease. Nobody came up with the answers of the positive family history straight away, but the patient was hospitalized, patient was repeatedly seen and kept on asking the question, and ultimately they we realized that, oh, okay, fine, this patient is having Huntington's disease, because unfortunately, again, we don't have the genetic testing in Pakistan, so we were compromised. It was more of a clinical diagnosis rather than a diagnostic. They include jerky movements, uncontrollable movement of the limbs, trunk, face, progressive loss of mental abilities, development of psychiatric problems, especially psychosis. It is hereditary, and maybe one child is affected, but 50% chances that there are other family members who are affected as well. If you ask me, there is again, unfortunately, no specific treatment for Huntington's disease. We usually treat the psychosis and try to improve the quality of life. Usually, these people don't have, again, a long life. They usually pass away earlier because of the complications of the Huntington's disease. Not because of Huntington's disease, but because of the complications generated secondary to Huntington's disease. Am I clear? Oh, you have raised the arm. So I'm sorry. I was not able to see that. Go ahead.
Sir, I have 2 3 questions. मैं एंड में भी पूछ सकती हूँ जैसे भी आपको सूट करे.
थोड़े से लोग हैं. People are not interested in these lectures. So go ahead. No worries.
Okay. सर मेरा सबसे फर्स्ट क्वेश्चन ये है कि आप बता रहे थे जब आप ब्लेफरोस्पैज्म की बात कर रहे थे मसल डिस्टोनियाज में, आपने कहा कि जैसे आपके अंडर केयर पेशेंट्स हैं लाइक मे बी 10 to 15 जिन्हें आपने देखा है विद ब्लेफरोस्पैज्म. मेरा ये क्वेश्चन है कि वो जो सब पेशेंट्स थे उनमें वो जो डिस्टोनियाज थे वो एज अ रिजल्ट ऑफ साइड इफेक्ट्स ऑफ साइकियाट्रिक मेडिकेशन थे या कुछ में विदाउट साइकियाट्रिक
So no previous history of medication, no previous history of any treatment. They went to multiple physicians and then they were given some medications like SSRIs and other stuff. But usually that is not the solution. So वो जो जब हिस्ट्री आप लेते हैं, yes, the primary importance is कि are they taking any medications for it, which may be causing the side effect as a blepharospasm. So nothing like that. So they were diagnosed lingual dystonia. I still write my diagnosis on the side. Just if the patient goes to somebody else, they know what I'm treating. So it's relatively easier for other people to understand as well. So two of my patients who are having lingual dystonia, they presented क्योंकि जबान दांतों के बीच में बहुत ज्यादा आ जाती है और उसके बाद उनको बोलने में दिक्कत होती है और टंग ट्विस्ट्स होते हैं. No, again, past history of medication, nothing. So we were trying to address that lingual dystonia.
So as a psychiatrist, what is our role in that?
It's not our role majorly. If you ask me, no. Again, because those patients were seen by me in my clinic, referred by somebody known to me, I took the opinion from the neurologist, I took the opinion from the ophthalmologist. They also wrote some kind similar. Then the patients remained with me for a longer period of time. I kept on trying again various combinations of the medications to improve the quality of life. The quality of life was definitely much better. I sent them for Botox as well, but unfortunately, most of the people in the market, they were not able to say comfortably where to inject the Botox in lingual dystonia. So I was hesitant myself because I never had the experience about it. And that was one of the reasons why I sent them to the neurologist. But the neurologist never went for Botox. He just changed my medication, which was the patient was not comfortable with that. So they came back. So that's the whole story behind it. Again, lots of ifs and buts associated when we are practicing psychiatry in the market. So I still feel that there are complications associated, but we have to be careful, right?
Yes, sir. So one more question. Thank you.
Sure.
First of all, thank you. Sir, दूसरा question ये है कि when we were talking about essential tremors, you said that the most safe option according to you is either benzodiazepines. My first question is benzodiazepine addiction नहीं होगी मतलब is it a
अब कुछ
preferable option?
सिचुएशंस ऐसी हैं, लाइक एक पेशेंट मेरा है जिसको सेरेब्रल पाल्सी है, राइट? अब सेरेब्रल पाल्सी में ऑलरेडी बहुत सारी चीजें कॉम्प्रोमाइज, वी ऑल नो. Cerebral palsy में main stay for stiffness, treatment for the stiffness is a benzo, long-acting benzodiazepine, and clonazepam is recommended there, along with baclofen. So that is one of the treatment which is recommended for in patients who are having severe stiffness in cerebral palsy. Same goes here as well. When I know the diagnosis that this patient is actually having, say, essential tremors, and he won't be able to respond to any other thing. So I will go for, yes, first initially the treatment which is less harmful, like carbonic anhydrase inhibitor. और वो डायामॉक्स के नाम से पहले आती थी. अब मैं डायामॉक्स से शिफ्ट होके लकोसमाइड पे चला गया. सो ऐसे पेशेंट को आई ट्राई लकोसमाइड, बट अगेन those acetazolamide, but those medications, they are mild and most of the time they are not helping. So if that is not helping, then under the drug list which is recommended for a disorder, benzo is one of them, long acting benzodiazepine. The hazards of yes, dependence are always there, but we have to weigh the risk and the benefits. In some people, these drugs play a miracle role and they are very comfortable with it. And if they are comfortable and they are not developing any side effects on the low dosage, and we are not escalating the dose, and there is chances of not abusing the drug, why not?
Okay. Okay, sir.
Right?
And
Okay.
so
What else? Yes, go ahead.
Sir, when you were talking about Huntington disease, उसमें आप एक एग्जांपल भी दे रहे थे पेशेंट की. So for example, अगर किसी पेशेंट को Huntington disease है या कोई और मूवमेंट डिसऑर्डर है ऑलरेडी और वो साइकोसिस के साथ प्रेजेंट करें और जब हम उन्हें एंटीसाइकोटिक्स देंगे तो उनके मूवमेंट डिसऑर्डर्स वर्स हो जाए, मतलब होने के कितने चांसेस होते हैं, क्या चांसेस होते हैं, और वो उसकी
पास्ट में अगर ये बात की जाती है आज से 15 साल पहले तो शायद मैं कहता कि मुश्किल होगा, लेकिन अब तो बहुत सारी साइकोट्रोपिक्स, एंटीसाइकोटिक मेडिकेशंस अवेलेबल हैं जो डोपामिनर्जिक सिस्टम को ज्यादा डिस्टर्ब नहीं करती, लाइक
उसमें सेफेस्ट ऑप्शंस कौन-कौन सी होती हैं सर?
कोटायापीन, ओलैंजापीन एंड क्लोजापीन. and the new ones, there are जो नई हैं उसमें brexpiprazole, again depending upon person to person, it is considered to be relatively safe, और cariprazine का भी बारे में ये कहा जाता है कि chances of developing EPS are much less. So we have multiple options available in the market now. 15 साल पहले ये ऑप्शंस अवेलेबल नहीं थी, लेकिन ओलेंजापीन जब लॉन्च हुई तो उसने बहुत सारी इन चीज़ों को एड्रेस कर दिया, लेकिन उसके अपने मसाइल हैं, वेट गेन है, डायबिटीज है, मेटाबॉलिक सिंड्रोम है. सो वी हैव टू वेई द रिस्क एंड द बेनिफिट्स इन द क्लिनिकल सेटिंग, व्हाट प्रिसाइजली वी वांट टू ट्रीट. और मैं हमेशा ये मना करता हूँ कि तुम लोग हमेशा दवाइयों पे जाते हो. पहले डिसऑर्डर को तो अंडरस्टैंड कर लो, बाद में दवाइयों का पूछना.
ओके,
ठीक है, पहले डिसऑर्डर को अंडरस्टैंड करो, दवाई बाद में पूछना. दवाई आखिरी मरहला है, पहले साइकाइट्री में असेसमेंट है जरूरी. है क्या, वो है क्या, अगर वो डायग्नोसिस कंक्लूड कर लिया तो फिर दवाइयों की लिस्ट तो नेट पे अवेलेबल है, क्या क्या ट्राई की जा सकती है इस डिसऑर्डर में. उनमें से ट्राई कर लो जो सेफली अवेलेबल है. सो दैट इज नॉट अ बिग डील. सॉरी, खुद ही बोलना शुरू. ओके, multiple system atrophy. Again, I haven't seen a patient of multiple system atrophy like Shy-Dagger syndrome, striatonigral degeneration, orthostatic hypotension, male impotence, and urinary difficulties. Most of these people of multiple system atrophy, they present to the neurologist. So I haven't seen any of them in the clinical practice, so I'm just skipping it. Myoclonus. Myoclonus is one of the most common presentation in psychiatry for movement disorder. Rather, I will say that this is more common than now with new second, third generation of antipsychotic medications. Myoclonus is more common than EPS. Myoclonus is a twitching or intermittent spasm of muscle or a group of muscles. Myoclonus is classified into several major types and many subcategories. The most common type is cortical myoclonus, which arises from an area of the brain known as sensory motor cortex. Jerky movements usually have regular rhythm and may be limited to one muscle or group of muscles, several different muscle groups, multifocal. They may occur without an obvious cause or be a result of many diseases. Like, if I will be asked about myoclonus, as I said, if my patient is on SSRI or quetiapine or some other drug, they usually present with the myoclonus. Now, myoclonus have multiple, again, associated diagnoses. Like, they can happen in celiac disease, Engelmann syndrome, Huntington's disease, Creutzfeldt-Jakob disease, Rett syndrome. They could be drug-induced, SSRI-induced myoclonus, or antipsychotic-induced myoclonus, Alzheimer's disease, hypoxia, liver failure, multiple sclerosis, syringomyelia, trauma, ischemic myelopathy, herpes, Lyme disease, E. coli, HIV, hemifacial spasm. Now, why I'm saying this is more common? Because one thing which is written in white here is drug-induced. Most of my patients who are on SSRIs, say treated for OCD, high dose of an SSRI, they develop myoclonus. So what happens is they complains कि जी बैठे बैठे एकदम हाथ ऐसे करके हिल जाते. One, unilateral and spastic movement suddenly. Now that sudden movement, I will always think of myoclonus. या रात को सोते वक्त बेगम शिकायत करती है कि आप कभी कभी रात को जोर से लात मार देते हैं. Right? Now, that is unusual. That is specifically myoclonus. And if he's on SSRI or some antipsychotic medication, I will definitely go for it. One of the common thing about problematic thing about myoclonus is that it could be, again, similar to an epileptic seizure as well. So that's the tricky component in it, but it is commonly seen. Barbiturates, so most of the treatment is anticonvulsants. Like, not, I won't go for barbiturates, but I will definitely go for divalproex. or clonazepam, depending upon, again, the situation and the past history and other evaluation processes. So anticonvulsants are the treatment of choice for myoclonus. If you feel that the patient is having OCD and he is stable on 80 milligrams of fluoxetine and he is developing myoclonus secondary to it, I will go for a benzo or an anticonvulsant to control the myoclonus. In majority of the situation, it's definitely helpful, so I don't mind that. Parkinson's disease, progressive disorder that is caused by degeneration of the nerve cells in the part of the brain called substantia nigra, again basal ganglia, which controls the movements. The nerve cells die or become impaired, losing the ability to produce dopamine. Now, this is a very tricky situation. Once the person develops Parkinsonism, very recently, one of my patients passed away actually. Or वो हुआ ये कि he came to me with typical symptoms of Parkinson's. And although, again, I am not a neurologist, but they have been to multiple neurologists and they were not happy. So I tried giving them the medication and he was stable in 6 months' time. He was imam in a mosque and he started going back to the mosque and do the imamat. But of course, he was on a combination of a complex medication regime, which of course I am treating over the period of 6 months. I kept on adding, subtracting, and managing, and he got well. Then the relatives started saying that you are taking so many medications, so you should take another opinion. They went to the neurologist. The neurologist said that this combination is a strange combination. They tapered down the medication. He relapsed and he passed away. So you have to be careful about these issues. If a patient is stable with the medication from another person, don't bother to simplify the regime because you don't know the past. Keep seeing them, keep assessing them, keep evaluating them. And if you come to the conclusion that the prescription written for polypharmacy was done in a short period of time for a specific diagnosis, then you may simplify the regime. But if the complex polypharmacy was given to the patient over the period of years to correct the symptoms, be careful not to stop them suddenly or be hasty in your decision of giving rise to, again, conclusions ke ye band kar do aur ye shuru kar do. Don't do that. Common symptoms including tremor, muscle rigidity, stiffness, slowness of the movements, slower mental capabilities, slow reaction times, voice changes, decreased facial expressions, gradual loss of automatic movements like walking, unsteady gait, flexed posture, bending at the elbows, knees and hips, drooling, maybe sometimes depression and dementia. So there is a whole range of symptoms. Tardive dyskinesia. TD is a muscle disorder that results from prolonged exposure to some types of antipsychotic or neuroleptic medication. It's not prolonged exposure. It is an actually idiosyncratic reaction. These days I am seeing recently again, सारे मैं recent मिसालें दे रहा हूँ. I am seeing a patient who is developing tardive dyskinesia for almost a year and they were never bothered to actually come back and saw me. The antipsychotic was prescribed by a psychiatrist who left the country, Canada, of course, who left the country. He was very much stable as far as his symptoms were concerned. They continued the medication. And after 2 years, they came back with some abnormal jaw movements, continuous abnormal jaw movements. The moment I saw him, I said, oh, this is TD. And then when I realized that he is on lorazepam, it was complicated. And I asked them the question, why you never bothered to consult a psychiatrist or a physician when he started developing these movements? And they said, well, he was so well that nothing happened. But then they went to the family physician. The family physician saw the movements. He added actually anticholinergic drugs, which are unfortunately not a right choice. If a patient is developing tardive dyskinesia, anticholinergic medications should be discontinued rather than the dose is increased. So anticholinergic drugs in tardive dyskinesia are contraindicated. They should not be prescribed. TD may be mild, which is irreversible, but most of the time, if it is established, if it is severe, it is mostly irreversible. There is a long list of medication which you can try in tardive dyskinesia, but no conclusive medication is available for this treatment. Tourette syndrome. Now, Tourette is again inherited disorder, neurological disorder of involuntary movements, uncontrollable vocal sounds called tics. So in Tourette syndrome, they have again vocalization, grunting, throat clearing, shouting, barking, coporolalia, galiyan nikalte, and sometimes coporopraxia, obscene gestures, which are unfortunately the problem. So verbal tics, if they are there and they are making strange noises, and off and on, you're sitting in a public place, social gathering, and the patient starts doing once or twice. Those abnormal vocal sounds, you should always think about Tourette syndrome. And if you go into the detail of the history, well, he's been having this for so many years, since the childhood. He wanted to make these kind of noises. We were initially embarrassed and then we were comfortable. So the parents are not bothered about it because they feel that nothing is wrong with him. It's just that he makes sounds. Especially when the other specialty doctors say, okay, he makes the noise, ultrasound kara lein, CT kara lein, MRI kara lein, and nothing's coming up, and they say, well, this is nothing wrong with him. He is, again, doing it by himself voluntarily, so nothing needs to be done. And sometimes it remains there for a long period of time, and it's a problem only when he starts doing, again, some obscenities, or he starts publicly disinhibited behavior, sexual exposures, or he started again swearing too much. Lots of people swear, but the swearing in Tourette syndrome is a long-lasting one. Even today, I saw a patient and he was actually swear a lot. गालियां निकाल सड़क पे चलते लोगों को बातों में दफ्तर में काम पे घर पे गंदी गालियां. And the patient said कि जी इसमें तो हमने मास्टर किया हुआ कि हम गंदी गालियां निकालते हैं. But if you look at the background and you try to assess him from the birth till today, you will be able to understand, there is something wrong. So the behaviors are not the only problem. Vocalization of obscenities and coprolalia is a problem. The onset is around the age of 15, right? So during the adolescence time period, he will start saying these words, and that is part of the habit then, long standing. Wilson's disease, you just named it, a genetic disorder, autosomal recessive. Liver disease is a problem. Usually patient presents with either abnormal movements, but the first presentation is usually the liver problem. Homicidal, suicidal behaviors, depression, aggression are common psychiatric presentations of Wilson's disease. The best part is that you can assess the patient, like you can go for serum ceruloplasmin levels, just serum ceruloplasmin levels. And if they are high, there is one drug available in the market, which is a chelating agent, and you can start him, penicillamine and or zinc acetate, and the patients do very well on that. Usually penicillamine is the drug of choice, and the physician or the neurologist prescribe it, and usually the patients are very stable. The problematic situation is that patients' Wilson's disease can be controlled, but the psychiatric symptoms developing secondary to Wilson's disease are very problematic and very difficult to treat. And most of the time, the psychosis is such that paranoia, mostly, specifically to the parents and the family members, difficult to treat and difficult to manage as well. Okay, other less common disorders like supranuclear palsy, Rett syndrome, secondary Parkinsonism, and spasticity are some of the things that usually are presented. Again, now I can take the questions. किसी ने और पूछना है. Yes.
Yes, sir. I have a question.
Sure.
सर माय क्वेश्चन इज कि जैसे अभी आपने बताया कि टार्डिव डिस्काइनेसिया के अंदर एंटीकोलिनर्जिक ड्रग्स जो हैं वो कॉन्ट्राइंडिकेटेड होती हैं, तो इसका थोड़ा मैकेनिज्म ऑफ एक्शन आप बताएंगे कि इसका मतलब क्या इसकी वो होती है पैथोलॉजी, व्हाई इट हैपेंस, बिकॉज ऑफ द समथिंग लाइक
मुश्किल सवाल
सुपर
पूछ लिया।
सेंसिटिव।
अच्छा, उसमें होता यह है कि tardive dyskinesia usually develops in people whereas there is an imbalance between the dopaminergic and acetylcholine system, right? So it's not only the dopaminergic thing which is causing the tardive dyskinesia. It's actually the balance between the two neurotransmitter system, the dopamine and the acetylcholine, which is a problem. So if it is established and so there is an imbalance between the two system neurotransmitter system, you give anticholinergic, it will further go down and the dopaminergic system will further go up and the TD gets worsened. समझ आई?
Yes, sir.
Okay.